Dr. Ben Tran is a medical oncologist here at Peter Mac, and he also works at the Walter and Eliza Hall Institute of Medical Research. He's going to give us some insight into the changing landscape of treatment. Please make him welcome.
Thanks, Julie. Thanks, Julie, and thanks to the PCFA for inviting me to speak, and welcome to my second home, Peter Mac, or as my wife would say, my first home. I spend more time here than actually with the family, unfortunately. So today I've been asked to speak about the treatment landscape that we have for prostate cancer, but as a medical oncologist who treats mainly advanced cancer, I was going to focus on that, what we do now and how quickly things have changed over the last decade or so, and how quickly I think things are going to continue to change over the next several years. And like all researchers, we work a lot with the companies that make the drugs, and you can see here I work with them all very evenly. So I'm going to speak about the landscape, what we do a little bit for local disease, for prostate cancer that can hopefully be cured, and then for advanced disease where we're hoping to control the cancer and keep out the patients' lives well into the future with an excellent quality of life. And then I'll touch a little bit on new treatment options, the role of personalised medicine, the role of immunotherapy, which I'm sure you've all heard about in the news with Ron Walker and Jared Ruffhead receiving that for their melanomas. And then a little bit about the lutetium PSMA, which is developed here or one of the main centres here at Peter Mac, and has received a lot of media and support from the PCFA recently. So I can't really put everything to scale, but this puts categories over what treatments sit where. If we talk about local prostate cancer, there's three major ways you can treat that. Active surveillance, which I'll touch on, removing the prostate with surgery, or radiotherapy, which is often combined with hormonal therapy, what we call ADT, or androgen deprivation therapy. Then there's a period where you haven't had hormonal treatment, and we kind of call that castrate-naive or castrate-sensitive disease, and I can talk about that in a bit. And then castration-resistant disease is where all the new drugs are coming, and I'll spend a lot of time on that in the coming minutes. So when you have your prostate, or when patients are having their prostate removed for prostate cancer, there are a couple of different ways that can be done. One of the leaders of robotic surgery works at the Royal Melbourne, Tony Costello, amongst others in Melbourne as well. And they've been using this robotic machine made from Da Vinci, you can see it here, where arms are put into, these little devices are put into the abdomen of the patient, and it's all controlled from a console here. So the surgeon sits there, they don't need to scrub up and they don't need to have special gowns, so you can see there they are wearing what we call scrubs. And by sitting there, it gives you an excellent 3D image of what's going on inside the abdomen. And the control using kind of fingertip devices allows very minute kind of movements to be made within the robot, but sitting there in the console. There's a lot of controversy over whether you should have a robotic surgery or open surgery. A recent study led by an Australian based in Queensland has suggested that it doesn't really matter. You need to follow what your surgeon is most comfortable with. An excellent open surgeon where they have large cuts of the abdomen to get into the prostate is just as good as a robotic surgeon. There's no difference in urinary or sexual function following surgery. There is slightly more pain within the first week, perhaps a longer stay in hospital, and perhaps less blood loss with the robotic approach. But overall, I think it's safe to say that if you've picked a surgeon, you need to go with what they're most comfortable with. If they're not an experienced robotic surgeon, but a very experienced open surgeon, then I think you'd go with the open surgery, whereas if you've chosen a very experienced robotic surgeon, then you should stick with that. There's some controversy over whether lymph nodes should be removed at the same time as removing the prostate as well. A lot of surgeons believe it gives you more information, whereas others believe it might cause some other side effects. So that's a discussion that many patients should have with their surgeon as well. An alternative to removing the prostate or prostatectomy is receiving radiation. And the way radiation is done is scans are done to see where the prostate is and where the cancer might be. And the radiation oncologist would sit down and, having had a discussion with you, would go back and have a look at the scans and draw diagrams about where the prostate is. And using algorithms and computers, it can be tracked exactly where the prostate is when you're sitting on the radiation bed. And using tattoos, so you do end up with a little tattoo if you have radiation, they can link the scan findings to your body, and you receive radiation for about 5 to 10 minutes each day for a period of 3 to 6 weeks, depending on the course of radiation that's been chosen. Often radiation is given with hormonal therapy, and hormonal therapy is now considered as an injection which reduces testosterone levels in your blood. And by doing that, that can increase the chance of cure. And so the duration of hormonal therapy with radiation treatment is debatable. Some people use up to 6 months, some others up to 3 years. And that's an important discussion to have with a radiation oncologist as well, if that's an option that you're going down. And a third option for patients with prostate cancer, which is localised to the prostate, is active surveillance. And active surveillance is just watching patients very closely. We now know after years and years of experience that some prostate cancers never eventuate to anything that can spread. And for that reason, undergoing serious surgery, which might have serious side effects, or undergoing radiation, which might have serious side effects, might not be necessary. And so there's some very clear criteria that have been developed to decide which patients can be watched very closely. And that's been shown that if you can watch these patients closely, that patients can continue on with their lives with minimal impact. This would include regular examinations, regular testing of the PSAs, sometimes MRIs, and sometimes biopsies as well. So I've covered the local prostate cancer briefly there. It's not something that I deal with very often. As a medical oncologist, I normally deal with prostate cancer that's become a bit more advanced. And so I'm going to talk a little bit about what treatments are given and why treatments are effective early on and a bit later in the disease course. What we do know is prostate cancer is very dependent on what we call androgens. And what androgens are really is testosterone. So testosterone is the main feeder of prostate cancer. And it's really our original, one of the original kind of personalised medicine approaches. We know prostate cancer needs testosterone, so the best treatment for prostate cancer where it's advanced and maybe can't be cut out or can't be gotten rid of completely is to get rid of testosterone. And in the old days, the best way to get rid of testosterone was to remove the testicles. Guys don't like that so much. And so for that reason, we figured out through science that the brain tells the testicles to make testosterone through different signalling pathways, and we can stop that signal with 3 monthly or 4 monthly or 6 monthly depot injections. And these injections are drugs that stop that pathway between the brain and testicles and can get rid of testosterone. And that's great for the prostate cancer, or for our patients with prostate cancer, because by getting rid of testosterone, the cancer is not getting what it needs to feed, and if it's not getting what it needs to grow and feed, then it can shrivel up and stay dormant and hopefully go away and shrink and have a non-issue for a long time. But what we need to understand, and what we've increasingly appreciated over the recent years, is that testosterone or androgens are really important for your body normally. And without testosterone, you can have multiple side effects. And whilst most of the side effects are kind of slow in onset and not really noticeable immediately, over time you can notice them if you've been on it for several years. The most immediate side effect is that of hot flushes. Essentially, by getting rid of testosterone, we're putting our patients into male menopause. And so my men with hot flushes, they don't get much sympathy from their wives, but it's something that they learn to deal with over time. There are medications you can have to reduce the severity of hot flushes as well. But over time, by getting rid of testosterone, your metabolism is dropped. And with the metabolism that's dropped, you can put on weight, and subsequently your risk of heart disease, your risk of diabetes, your risk of high cholesterol can increase. Your muscles can shrink down as well, and your bones can become a little bit weaker. These are things that happen to women in female menopause, and they can also happen when we're inducing male menopause as a treatment for prostate cancer. And the best way to counteract this is exercise. You would have seen in the media recently a lot of data around the importance of exercise for cancer. That is extra important for prostate cancer. Exercising, resistance training, trying to increase your metabolism, build muscle, can reduce the impact of a low testosterone on your body. What I say to my patients is, I can be sure that I can control your prostate cancer and treat it very well for a long period. What I don't want to happen is for you to develop a heart attack. And so the way to prevent that is to keep exercising and keep fit. It's a really important part of prostate cancer treatment. Sometimes when we start hormonal treatment, or ADT, androgen deprivation treatment, getting rid of androgens or getting rid of testosterone, we can adopt a start-stop approach. And the idea of a start-stop approach is to reduce side effects associated with having a low testosterone. Sometimes it takes a little while for testosterone to be reproduced by your testicles after you stop the hormone treatment. But once it does, it can improve issues like impotence or issues with libido and mental health. There might be a medium-term benefit on your general well-being and strength, but we're not really sure what the benefit in the long term of this intermittent approach is. We do know that patients' quality of lives can be improved with that approach. It doesn't have an impact upon survival if people are kept a close eye on by their doctors. And in certain populations and patients without metastatic disease where there's no spread of the cancer, it's definitely the same as continuing hormonal treatment continuously. But in patients where the cancer might have spread, we can't say for sure that it's the same, but it's something that we do adopt in some patients. However, in some patients, even though we know testosterone is driving prostate cancer to grow, and even though we can get rid of testosterone, in some patients over some time, the cancer might start to grow again. And the most common reason for that, and this is a complex diagram, but I'll talk to it, the most common reason the cancer starts to grow again is that it gets really smart and it starts to make its own testosterone to feed itself. And so if you took a blood test of patients in that situation, you would see no testosterone in the blood. But if you were able to take a sample of cancer, you would see a lot of testosterone within that. So that's the main way that patients become resistant to castration levels of testosterone. So resistance to the hormone treatment that we give. So this is the treatment landscape for patients with advanced cancer where it may have spread or where it might have been cut out, but the PSA's come back. What the PSA is a protein that the cancer makes that leaks into the bloodstream and that can be detected. So generally a higher PSA might mean a higher level of cancer, but you cannot compare PSAs between different patients. There's patients of mine with a PSA of 200 where you can't see anything on a scan, whereas you have other patients with a PSA of 0.5 where there might be a lot of spots on bones or lymph glands. So whilst you can't compare between two different patients, you can definitely compare within yourself. And so it's a good measure of what's happening within your body without having to do scans all the time. So if patients have cancer that has spread or patients where it can't be gotten rid of completely, then we'd call those patients as having advanced prostate cancer. And as I've mentioned, the best treatment for those patients is to receive hormonal treatment. And whilst we've mentioned a start and stop approach, it's something that you need to continue lifelong. And the reason for that is if down the track you stop the hormone treatment and the testosterone were to come back up, then the cancer might start to grow again. Up until kind of the late 90s, we didn't have any other treatments except for hormonal treatment to try and fight prostate cancer in this situation. But in 1996, my mentor, Ian Tannick, who I worked with in Canada, was able to show that an very old-fashioned chemotherapy now called mitoxantrone was able to shrink some patients' cancers and improve their quality of life. It didn't seem to make patients live longer on a kind of more population basis, but there was certainly some patients who benefited, and patients were definitely having improved quality of life with that treatment. But it wasn't until, so that was the only treatment we had for some time. Then in 2002, we developed a bone agent called zoledronic acid, or called Zometa now, which is an injection which is able to reduce the risk of the spots in the bones causing fractures or causing pain. So that became adopted as one of the options amongst the standard of care for patients in this situation. But it wasn't until 2004 when, again, my mentor, Ian Tannick, was able to prove that a new chemotherapy, docetaxel, otherwise known as Taxotere, was able to not only improve patients' quality of life, but also make them live longer. Docetaxel actually is a natural, kind of a refinement of a natural product. It comes from the Pacific yew tree, which I think grows down the west coast of the States. And they were able to isolate this chemical and show that it had activity in stopping cancer cells from dividing, and by doing so was able to provide benefit and shrink several types of cancers, prostate cancer being one of them. When you hear of chemotherapy, everyone gets a bit worried, but what most people know about chemotherapy is what you see in television, which is normally breast cancer or leukemia, where the chemotherapy is very severe. Chemotherapy for prostate cancer is much less severe. Many of my patients who work will continue to work. My patients who play golf will continue to play golf. And it might be only a few days out of the 3-week cycle that they might feel unwell. Chemotherapy is given intravenously through a drip, and you need to come into a hospital every 3 weeks or thereabouts for the drip to be given over a couple of hours before going home. We always recommend that for the first dose that you come with someone you know, but on subsequent doses, many of my patients will drive in themselves and drive home, or catch a tram in and tram home. So it's a sign that it is very tolerable, and not only is it tolerable, but it can provide benefit. So for some time, that was our main agent of choice for patients with advanced prostate cancer that had become resistant to the hormonal treatment. But then there's been an explosion of new treatments that have provided benefit. The first that came was this immunotherapy, Sipuleucel-T, where there was some controversy over whether it provided benefit or not. This is not available in Australia at the moment, and is also rarely used in America. It's very expensive, and it's not a treatment. It's not a drug as such. What happens is patients get blood taken. That blood is taken to a laboratory where it's primed against prostate cancer, and those immune cells that are primed against prostate cancer are then given back to the patient over three doses, 2 weeks apart. And that seemed to make people live a little bit longer. But again, kind of the benefit and cost-benefit ratio meant that it's not commonly used compared to some of the new treatments. In 2011, a second chemotherapy, also derived from the Pacific yew tree, was proven to show improved quality of life as well as improved survival in patients where the first chemotherapy, docetaxel, might not have worked so well. And then there's been a whole bunch of new hormonal treatments. In 2011, we proved that abiraterone, which is a new hormonal treatment, which I'll get to in a second, is able, and also a tablet, is able to improve patient survival. And then there was a new bone treatment, which instead of being an intravenous injection like the zoledronic acid, is a subcutaneous injection into your fat, was able to reduce the risk of fractures and pain in people who had spots in their bones. And then you can see how quickly things are developing in the last decade or so. Enzalutamide is another hormonal treatment, and I'll describe the difference between abiraterone and enzalutamide on the next slide or so. And then what we showed was not only did these hormonal tablets work after chemotherapy was given, but also before. Radium-223 is a really exciting radioactive treatment. Radium is similar to calcium, and it binds to the spot of your normal bone next to a spot of bone cancer within the bone. And in doing so, it gives out radiation to a small area around it. So in doing that, it's chipping away at the cancer in the bones, but it only works in the bones. In 2014, we showed that enzalutamide, one of these hormonal treatments, worked before chemotherapy, but one of the biggest advances we've been able to show, it was a very simple maneuver. All we did was try the chemotherapy at the very beginning alongside hormonal treatment. And so now this is a standard of care with patients where the cancer is a little bit more advanced than otherwise. And by giving a short burst of chemotherapy at the very beginning when you're starting hormonal treatment, we were able to improve things by 40% across the board. And so that very simple maneuver, moving chemotherapy from later on to the beginning, has resulted in quite a significant improvement in patients with prostate cancer. It's a bit scary because you'd always thought that chemotherapy was the last option. Now we consider in some patients to be the first option. And then alongside that, which is it made everyone's kind of ears, made everyone a little bit more comfortable, these tablets, hormonal tablets, have also shown the same thing. As an alternative to chemotherapy at the very beginning as a burst, having these tablets as an ongoing treatment and might provide the same, or does provide the same sort of benefit. So just a little bit, this is a slide that shows how things work. If I concentrate on the abiraterone and enzalutamide, which are hormonal tablets, the way they work is that they act where the cancer's starting to make its own testosterone. So even though there's no testosterone in the bloodstream, if the cancer's making its own testosterone, the abiraterone breaks down the machines that the cancer needs to make testosterone. And by doing that, it is stopping the cancer from producing its own testosterone to feed itself. So that's how the abiraterone works. Abiraterone needs to be taken as a tablet on an empty stomach, and you need to receive some steroid medication alongside it to help some of the side effects, but it's very tolerable. The enzalutamide works a little bit differently. It works by stopping the testosterone that may have been produced by your testicles or by the cancer itself from attaching to the cancer and making it grow. So both work very similarly, and for that reason, if one stops working, the other is likely not to work as well. So it's really two different ways of doing the similar thing. Chemotherapy bypasses that whole thing and goes straight into the cancer and stops it dividing, and that's how it kills the cancer. And as I said, the Sipuleucel-T is activating these immune cells called T cells to fight the cancer, whereas the radium-223 is this little deposit, this little yellow dot here, which attaches to the spot between normal bone and a spot of cancer within bone, and it kind of zaps it over a small area. The bone agents that I spoke about are really important. The bone seems to be a feeding ground for prostate cancer as well, and that's why it seems to spread there. The denosumab and the zoledronic acid stop some of these signals that are created by the bone and try to prevent the prostate cancer from depositing there. And they can also strengthen the bone and reduce the risk of fracture and pain. So we spoke about all these treatments for patients who might be resistant to hormonal treatment or castrate resistant. But what we're noticing is that they're all kind of good options now. And the difficulty we have now is not what to use, but how to use it and what order we use it in. Should we have chemotherapy first or the hormonal tablets? You should have the hormonal tablets first. How do you flip them around? So that question is continually evolving, and it's a great problem to have. Before we had a problem of not having any treatments available, but now we have the problem of how best to give them, to minimise side effects and maximise effectiveness on our patients. So where are the treatments going to next? So I'll speak a little bit about personalised medicine and these things called PARP inhibitors, a bit about immunotherapy, and a bit about what I'm sure you're all excited to hear about, which is this lutetium PSMA, which has been in the news recently. Personalised medicine is a bit more difficult in prostate cancer than other cancers. When you look at the genetics of prostate cancers, there aren't many changes in there. For smoking-related cancers like lung cancers, you're damaging the DNA a lot, and there's a lot of mutations or genetic changes within lung cancer. In melanoma, the UV rays are kind of damaging the DNA a lot, and you get all these mutations. But in prostate cancer, mutations aren't very common. The other difficulty with prostate cancer is that often the prostate is removed many years before it manifests as a problem again. And so if you're going to test the tumour specimen from 10 years ago, that's been stored. You'll be surprised, but every time you have a biopsy or surgery, those specimens are stored almost indefinitely. So when we're testing for genetic changes, we'd call the laboratory, get those tumour specimens up and do some testing for it. But there's a long duration between then and now when you need to know the results. And because prostate cancer can spread mainly to bones, it's harder to get a piece of tumour to do adequate testing for it. So there's some of the problems that we're encountering in trying to personalise medicine in prostate cancer. But there are some potential success stories which I'll speak about, but also an unsuccessful story which you may have heard about. So we'll speak about ARV7 initially. So ARV7 is an androgen receptor variant, and it means that that little receptor where the testosterone binds to is unusually and abnormally constantly active and telling the cancer to grow, even though there might be no testosterone telling it to do so. And so some data out of Johns Hopkins in the States suggested that if you had this variant of the androgen receptor, that the new hormonal treatments didn't work very well. And then there was data saying that this brand new hormonal treatments seemed to work in this group of patients, whereas these older hormonal treatments, which weren't really that old, didn't work well at all. So there was a lot of excitement and a lot of money spent on a clinical trial to show that whether this new drug was able to improve outcomes or not, but it didn't. And it didn't because the science was evolving so quickly. We used to think that the Xtandi or the enzalutamide and the abiraterone didn't work in these patients at all. But the fact is that they still worked, just were less likely to work. And avoiding or withholding those treatments from these patients wasn't fair, and this new treatment didn't seem to provide any additional benefit over the abiraterone and enzalutamide at all. But one of the more potential success stories are these PARP inhibitors. And the way I like to think about it, I'll tell a story to try and describe it, but if you think about a normal cell, as it's dividing, into kind of this, let's say a cell on your nose or your skin or something, it's dividing naturally, it's always constantly dividing. And as it's dividing, errors are created within the cell. But your body and the genes have a great way to repair any errors so that your nose in 20 years' time looks the same as your nose looks now. But the problem is in some patients, and these are the patients with a BRCA gene or a genetic type of cancer, there's a deficiency in the repair of the changes as they happen. So as the cells are dividing, this might develop some weird error, but your body can't repair it because you don't have the machines to repair it. And in that case, that might become a cancer. But that same susceptibility to developing cancer is a weakness within the cancer itself. So as the cancer is dividing and growing, it too develops errors in its own genes, and it too can't repair them. But it recruits something called PARP, P-A-R-P, a new machine, to try and fix itself so that the cancer can continue to survive. And so we know in those patients that if you can find the original gene being impaired, meaning they don't have the main gene to repair themselves, then having a PARP inhibitor blocking the new machine, blocking what I like to call the external auditor, can help. And so a lot of trials are being conducted around the world, including in Australia, for patients who have genetic changes within their prostate cancer. It doesn't necessarily mean that you have a genetic change within yourself that you pass on to your children. Those genetic changes can just occur in the cancer as well. And so at the moment, we're testing people's blood as well as testing people's tumours, looking for these genetic changes. And if you have those genetic changes, these trials testing these new drugs are available. So this next slide just describes that about 12% of prostate cancer that's spread seems to have some sort of genetic change. It's dominated by this BRCA gene, BRCA2 and BRCA1, which are the ones that are more common in breast cancer and ovarian cancer. But there's a whole bunch of other genes which we think are important in the repair that I was talking about. We're just not sure if they're important in the risk of developing cancer as well. So this is one of the trials led by a colleague here at Peter Mac when she was working the Marsden, Shanine Sandhu, who showed that if you had this genetic change, then these PARP inhibitors or olaparib would work quite well. If you didn't have the genetic change, it didn't seem to be able to work. So at the moment, as I said, a lot of clinical trials using PARP inhibitors in prostate cancer. An old-fashioned chemotherapy called platinum seems to work in a similar way. So our big question now is, are these PARP inhibitors really sufficient to outsmart the cancers in these patients who have these genetic changes? Immunotherapy, very exciting, lots of cancers. In prostate cancer, a little bit less exciting. And immunotherapy involves using a drug which wakes up your immune system to fight the cancer. If you look under the microscope, you might see cancer cells there, and in some patients you see very, very angry immune cells next to the cancer. They've recognised the cancer as being a bad thing and they want to fight the cancer. The cancers get smart and put the immune cells to sleep with a mist. And so in those patients, if you can give a drug that relieves the mist, those immune cells wake up and start fighting the cancer and can be very effective. The problem is in prostate cancer, a lot of these immune cells are not angry. They're friendly. They're sitting around with the prostate cancer. They don't realise it's a bad guy, and they're sitting there, and there might be a mist created, but it doesn't matter because if you get rid of the mist, nothing happens. Those friendly immune cells just wake up and have a chat and a coffee with the cancer, not doing much else. So what we're trying to do is trying to get the angry immune cells into there. Now, we're doing lots of trials around the world, but here as well in Peter Mac and other centres in Melbourne, some people think that if you give radiation, a really strong dose of radiation to one or two of the spots of cancer, you can release these fragments and allow the immune cells to recognise the cancer as being a bad guy. Some of the trials I'm doing here are little proteins that drag an angry immune cell on one arm, drag it into the prostate cancer with the other arm. So there's lots of ways we're trying to improve the role of immunotherapy in prostate cancer. But at the moment, it doesn't seem to do the job. But watch this space. We may be able to change that very soon. So the last thing I wanted to speak about is lutetium PSMA. So many of you may have had a PSMA PET scan around Melbourne. It seems to be a very common thing in Australia at the moment. It's not very common at all in other countries, but a PSMA PET scan is a little protein that's got a little bit of radioactive stuff that can be picked up on scans attached to it. And that little protein attaches to PSMA. And PSMA stands for prostate-specific membrane antigen, or a protein that's specific to prostate cancer. The thing is, it's a bit of a misnomer because lots of other things in your body have PSMA as well. It's really prostate non-specific. So you inject this dye in and it lights up where the prostate cancer is supposed to be. But the guys at Peter Mac here and some guys in Germany have done, instead of attaching a little tracer that we can find on a scan, they've attached some radioactive material. And so you injected this little protein with radioactive material linked to it, and it kind of localises to where the prostate cancer is, and it gives radiation. And so it's a very early treatment, very promising. Trials have been supported by the PCFA. The therapy study, THERA, big P, has started, run through ANZUP, one of our collaborative groups. And that's comparing this lutetium PSMA to the cabazitaxel chemotherapy. So looks like a promising, really good treatment that works in some patients, as Jim has said. We're just not sure how good it is compared to chemotherapy yet. So that's the current trial we're conducting, comparing this new exciting treatment with chemotherapy to see if it's at least as good as chemotherapy. So those trials are ongoing, and hopefully it is, and then it'll go from there and might become a standard treatment over time. This is what we call a water floor plot, and this is how much PSAs have dropped or even increased when you're on the treatment. And you can see that at least half of the patients have had their PSA dropped in half with this new lutetium treatment. So it's a very exciting treatment, just to watch this space. So kind of in summary now as I'll close, local treatment approaches are really changing, but we're figuring out now that even if there is prostate cancer, it doesn't necessarily mean you need to treat it and get rid of it. It might be something that just sits there and doesn't do much for a long, long time. The landscape of treatment for patients with advanced cancer has changed dramatically and continues to change dramatically, and new treatments are developed all the time, including in our own backyard. So thank you.
Thank you.